Hi there, this is a Tutor to You MCQ revision blast. We're going to be looking at psychopathology from the AQA A Level. This is test number 4, so don't forget to check out our other videos as well. The format in terms of how these work is that they're based around 15 questions. Now these are MCQ questions. They're not the type of MCQ questions really that you'd expect to see in the exam. Just using MCQ in this way is a nice way for us to pick out some kind of key areas that you're going to need to know. So pause the video when I've gone through each question, take a little bit of time to think about your answer, keep your score as you go along, compare how you do on each of the videos. Alright then, off we go with question number 1. Alright, we'll get started then with question number 1, which is which of these describes the definitions of abnormality named on the specification? So on your spec, definitions of abnormality are named. Is it A, B, C or D? Take a moment to read through and pause the video. Alright. The correct answer that we're looking for here is D. Now each of these definitions of abnormality are named individually on your specification, so there's lots of potential questions that could come from these. Let's say it might be a STEM question where you're asked which definition of abnormality best explains a given scenario. There could be a 16 marker or a 12 marker AS on outline and evaluate definitions of abnormality, in which case be really careful about overwriting your AO1 when you know all 4 of them. Or application essays where you're asked to apply your knowledge as well as outlining and evaluating the definitions. So my advice here is to have a go at writing the outline of the definitions for up to 6 marks, just so you know in the exam exactly how much you can write in that time should it be an essay question. But also bear in mind that you could be asked short answer questions on each of these individually as well. Another word of warning really with the definitions of abnormality that's come up in the past. Be careful in your evaluations that you don't give that kind of generic evaluation. A lot of students, for example, refer to kind of cultural relativism in relation to kind of FFA and deviation from ideal mental health, but never really elaborate in terms of why that actually is. Okay, second question. Is the following a behavioural, emotional or cognitive characteristic of a phobia? And we've got presented with the object or situation they fear, their immediate response is to avoid it. Now is that A, a behavioural characteristic, B, emotional, C, cognitive, or D, all of them? So pause the video. Right, the correct answer is A. Now this is a really important question as it highlights just how much you're required to know about this particular bullet point of the spec. So we've got OCD, depression and phobias, and you have to know behavioural, cognitive and emotional characteristics. Now that's a lot to remember. It's like 9 areas of knowledge if you think about it. Now questions like this are a really easy way for examiners to check your knowledge of these characteristics, as well as you having described, for example, what a behavioural characteristic of a phobia might be. So in the case here we're referring to avoidance of the thing that's feared. If it were a cognitive characteristic we might talk about some kind of irrational thought process you have, and if it was emotional we might refer to kind of unreasonable levels of fear. Okay, for question 3, we're looking for what symptoms of depression is Jim experiencing, and we've got for a number of months Jim has been unable to get a good night's sleep. He often wakes up and is trapped in a cycle of negative thinking. So is that A, behavioural and cognitive, B, cognitive and emotional, C, behavioural emotional, or D, behavioural, cognitive and emotional? So pause the video. Right, correct answer here is A. Now the advice here on these types of questions is to read the STEM and stick with the information that you've been given, because there's nothing on here that actually describes any emotional characteristic. Now if we were to add in that most of the time Jim experiences intense periods of sadness, then that would be an emotional characteristic. So we've got a behavioural characteristic of depression, his reduced sleeping. For behavioural characteristics we might also see kind of changes in eating from normal functioning, either kind of under or overeating. And for cognitive, in terms of depression, you have that negative, that faulty thinking, which is something we'll come back to a little bit later on. Question 4. Which of the following is an emotional characteristic of OCD? A, repetitive behaviours, B, depressive symptoms, C, selective attention, or D, obsessive thoughts? So pause the video. Right, the correct answer here is B. So A there is a behavioural characteristic. The behaviours are repetitive in nature, such as, for example, in OCD, maybe excessive hand washing. C there, selective attention, is a cognitive characteristic, and what happens in that is all your attention is drawn to a particular stimuli, and this also actually occurs in phobias. D there is a cognitive characteristic, and these obsessive thoughts, one well-known one, I guess, being fear of contamination. And so B there is an emotional, and it's perhaps unsurprising that symptoms of depression can go hand in hand with OCD, often coming from the anxiety produced by the obsessive thinking. Now, just to go back to what I said before, knowing that you've got to know 9 characteristics in total, it's worth trying to summarise these, like shown on the screenshot here. So this is from the Psychopathology course companion from the Tutor2 website. But basically what it does is it just gives you a nice visual way of remembering 9 distinct bits of knowledge there for this particular area of the specification. Okay, question 5. Which of these best describes the 2-process model? So take a moment just to read through those and pause the video. All right, the correct answer that we're looking for here is C. Now, the 2-process model is listed under the behavioural approach to explaining phobias on your specification. The key here with this model is to know that there are 2 processes involved, hence the name. So classical conditioning helps explain how we learn or acquire the phobia. That is to say, how the phobia starts through association. Think little Albert in this sense, the association of fear response when that kind of bar was whacked. And then there's the operant conditioning. So the operant conditioning is how the phobia is then maintained over time. And this mainly focuses on the idea of negative reinforcement, in that the avoidance behaviour of the feared object produces a decrease in anxiety. They then repeat that behaviour to maintain the phobia. So key thing, 2 processes, classical and operant conditioning, classical for how it begins and operant for then how the phobia is maintained. Question 6. Which terms are crucial in any description of systematic desensitization? So we've got A, hierarchy and relaxation, B, reciprocal inhibition and fear, C, flooding and anxiety, D, system and desensitize. So pause the video. All right, the correct answer that we're looking for here is A. So how do we know that these are the 2 most important terms for them? Well, we know because they're named on the specification. Both of these are named next to systematic desensitization, hierarchy and relaxation. So questions on this area in the past have often focused around scenarios of a person with a phobia, and you're then asked to describe how you would use systematic desensitization. Now, students tend to be quite good at giving a desensitization hierarchy, and there's one there just on the screen in terms of what that looks like. The idea is that the fear gradually increases. What students so often forget to do in the description of systematic desensitization is mention that at each stage in the hierarchy, it's crucial that relaxation is maintained. So systematic desensitization is basically counter conditioning. What we want to do is replace the response of fear with one of relaxation, and that's not going to happen if the patient is left screaming at the end of stage 3. Now, in B there, we've also got a term reciprocal inhibition. Now, although that's not explicitly named on the spec, it is a nice key term to use in this context. Basically, it means that fear and relaxation are incompatible emotional states. If you think to your biopsych and parasympathetic versus sympathetic, basically you can't be both at the same time. And that's why relaxation is so important to help us lead to the extinction of that phobia. I would say with this question that it has been noted in kind of previous exam series that when this comes up, the weaker students tend to lack kind of specialist terminology in your answers. So hopefully me going through that has just given you an idea of what the kind of specialist terminology is you might need. Question 7. In describing flooding, most students in the past have failed to include which of these in their descriptions? So take a moment to read through, pause it and decide if it's A, B, C or D. Right, the correct answer here is D. Now, it's interesting that in previous questions on flooding, students often forget to mention that a function of it was the prevention of avoidance. Remember, this is one of the main behavioural characteristics of a phobia and is mentioned also in the two-process model as being the thing that maintains the phobia through negative reinforcement. So it's worth thinking with flooding what the core stages are. Now, if you haven't already, I would strongly suggest going through the exam reports from previous year. They're available on the AQA website and they're an excellent way to see what students usually mess up on, and they also give you some excellent tips in terms of the things that you might need to watch out for. Question 8. When comparing systematic desensitization and flooding, which of the following statements is incorrect? So A, flooding is more ethical than systematic desensitization. B, systematic desensitization takes longer than flooding. C, both are ineffective if the phobia was not learnt. D, neither are very effective at treating social phobias. So I want to know which one of those isn't right. So pause the video. All right, now it's A, and you've probably got A, but this question's great because it gets us to go through some key things. Now, the main ethical issues here are consent and psychological harm. So for a person undergoing flooding, they're going to have to face their fear, so to speak, and some argue that an individual can never truly realise the full extent psychologically of what this is going to involve for them. After all, they've spent most of their life avoiding it, so can they really give consent when they can never really truly know what's involved? Now, with B, systematic desensitization, it's going to have to happen over a course of sessions, and that's going to vary in terms of the individual, and this can be off-putting for some people and lead to them not choosing it as a therapy because it can be a very time-consuming process. With C, there's a lot to be said about some innate fears that might be built in. The idea is that these particular fears are adaptive, so things like fear of heights and fear of loud noises. Now, the argument is then, if there's a biological basis to these and they weren't learned, then the process of them undoing them, whether it's using systematic desensitization and flooding, won't work. Same applies to D. Some phobias, it's believed, are the result of cognitive causes, not behavioural, and this seems particularly true of social phobias, and these may have arisen due to some kind of faulty thinking. So again, the argument is that if the cause isn't behavioural, then we can't actually undo it using a behavioural therapy. So a few nice evaluations there for systematic desensitisation and flooding. Question 9. Which of these is not part of Beck's negative triad? So you've got negative views about the future, negative views about the world, negative views about the present, negative views about the self. So pause the video. Okay, so your correct answer here is C, negative views about the present. It does actually sound right, but it wasn't part of Beck's negative triad. So remember, Beck said that depression is caused by negative self-schemas that maintain this kind of cognitive triad, if you like, which is basically a negative and irrational view of ourselves, the future, and the world around us. Now, for people who have depression, these thoughts occur automatically and very, very symptomatic of depressed people. And the idea being you get trapped in this negative cycle of thinking. Now, within this, there are a number of cognitive biases that are responsible for these negative schemas. So, for example, a depressed person may make what we call overgeneralizations, where they make a sweeping conclusion based on a single incident. For example, I failed one of my end of unit tests and therefore I'm going to fail all of my A-level exams. And I'm sure we've all been guilty of overgeneralizations at some point. Question 10. Which of these is the correct description of Ellis's ABC model? So read through each of them and pause the video. Okay, correct answer here is D. Now, according to Ellis, good mental health is basically the result of a rational thinking process, and this allows people to be happy and pain-free. Whereas depression, on the other hand, is a result of irrational thinking, which prevents us from being happy and pain-free. So Ellis proposed this three-stage model, if you like, to explain how irrational thoughts could lead to depression. Now, just to quote a line from, I think it's Hamlet and Shakespeare, there's nothing either good or bad, but thinking makes it so. And this is really true of Ellis's ABC model. The focus is really here on the beliefs. After all, if you think about it, the same activating event can happen to two different people, but the ultimate outcome, that's to say the consequences, will be very different for them. And this is all because of the beliefs that they hold. People who hold rational beliefs tend to have more positive outcome. Those irrational beliefs tend to lead to negative consequences and symptoms of depression. Alrighty, question 11. The goal of cognitive behavioural therapy is to A. Counter-condition the depression, B. Identify and challenge the negative and irrational thoughts, C. Release the repressed material from the unconscious, D. Increase the amount of serotonin. Right, pause the video. I'm sure you got that right. The answer there is B. So A there would be a behavioural therapy, so the counter-conditioning, I guess. C, releasing the repressed material from the unconscious, is psychodynamic. And then we've got increase the amount of serotonin is biological. And the reason that this is included is just so you can know that there's actually some nice comparison you can do with other therapies using your approaches knowledge. And that could really kind of pull in your AO3 quite nicely if you were asked to evaluate CBT. For example, you might want to consider that the biological approach assumes that depression is caused by a chemical imbalance. And that being said, if we're going to treat it at the cognitive level, which only addresses the negative thinking, the biological approach is going to argue, well, that negative thinking is simply a symptom of a kind of, let's say, a kind of imbalance in serotonin. Therefore, we're only actually treating the symptom of the disorder. We're not actually getting at the cause of it. So really nice way to bring in your approaches knowledge there if you were asked to evaluate cognitive behavioural therapy. Question 12. Which of these is not a method of disputing that could be used to challenge irrational thoughts? A, logical, B, empirical, C, pragmatic, or D, holistic. So which of those isn't a method of disputing? Pause the video. Okay, the correct answer here is D. Now, challenging irrational thoughts is named on the specification, so it's really worth having a look at how this might be achieved. And these are just some of the methods used. So Ellis's REBT, which is rational emotive behavioural therapy, uses a technique called disputing that basically undermines those irrational beliefs that cause the negative consequences. So one way to do this is to use empirical disputing method. And in this method, the therapist seeks evidence for a person's thoughts. So where is the evidence that that belief is untrue? No matter what the type of disputing might be used, the goal is, as the spec says, just to challenge the irrational thoughts. Question 13. Which of these statements about the genetic of explanation of OCD is incorrect? So we've got A, it's thought to be monogenic. B, it is thought to be polygenic. C, the COMP gene may be involved. D, the SERT gene may be involved. So pause the video. Right, correct answer here is A. Now, polygenic, if you didn't know, means involving multiple genes, and monogenic means involving a single gene. Now, we're not entirely sure how many genes are involved in OCD. Some suggest up to 230, but two of them that have been implicated in OCD with quite a lot of literature behind them are the COMP and the SERT gene. Now, the COMP gene basically regulates the neurotransmitter dopamine. Now, although these genes come in many different forms, one variation of this gene results in kind of higher levels of dopamine, and what we see is this variation of the gene in sufferers of OCD compared to without OCD. Now, the SERT gene, you might know the SERT gene as the 5-HTT gene, is linked to serotonin, and it basically affects the transportation of serotonin. Hence, SERT is about serotonin transporter gene, essentially. Now, when it affects the transporter mechanism with serotonin, it actually causes lower levels of serotonin to be active within the brain. So in sufferers of OCD, we tend to see lower levels of serotonin. All right, let's see if you're paying attention on the last question. Which of these statements about the neural explanation of OCD is correct? So have a read through, I want to know which one is right. Pause the video. Alrighty, your correct answer here is C, reduced levels of serotonin, high levels of dopamine. So think about it, serotonin's function is to basically regulate mood, and we often see in mood disorders you get this low level of serotonin. Remember earlier we talked about the emotional characteristic of OCD being depression, so it's not surprising that serotonin is implicated in both depression and also OCD. Now the higher levels of dopamine seem to be linked more to the compulsive behaviours involved, so that's not surprising considering that dopamine is also part of the reward system in the brain. Final question. What does the selective serotonin reuptake inhibitor drug do? So SSRIs, what do they do? So have a read through and pause your video. Okay, correct answer here, what we were looking for, is C. So SSRIs in terms of the mechanism is all about the transporter mechanism or the reuptake mechanism on the presynaptic neuron. So think about it, when serotonin is released from the presynaptic cell into the synapse, it travels over to those receptor sites on the postsynaptic neuron. Now any serotonin which is not absorbed into the postsynaptic neuron is then reabsorbed into the sending cell. What SSRIs do is they increase the level of serotonin available in the synapse by preventing it from being reabsorbed into the sending cell. It's like a shut door, if you like, on that transporter mechanism. And then this has the effect of increasing the level of serotonin in the synapse, which in turn improves the concentration of the brain chemical on the receptor sites on the postsynaptic neuron and basically intensifies the stimulation on the receiving nerve. Now, think about the description that I just gave you in terms of SSRIs there, in terms of how they work. It's absolutely littered with key terminology, and that's the kind of thing examiners are going to be looking for in the exam. Psychopathology, with the kind of big link to kind of biopsych biology parts, has got a big new set of key terms that you're going to need to demonstrate knowledge of. All right, just a few kind of key tips just to finish off here. The first one is examiners often comment on the lack of key terms, and hopefully I've drawn this out as I've gone across, in that some questions in particular, we spoke about the systematic desensitization and flooding question, key terminology has been known to be an issue. Know the B, C and E, that just refers to the behavioural, cognitive and emotional characteristics we went through. Avoid generic evaluation is something I always said and will say in all of these MCQs. Avoid that. It's a lab experiment, so lacks the ecological validity. Give your AO3 some hucking. Don't overwrite your AO1. It is only ever worth a maximum of 6 marks. Knowing your spec inside out is going to make sure you're giving the right answer in a particular question. AO2 is more than just a name. Be careful in your application questions. Make sure you go beyond just mentioning an individual's name. And please do not forget that research methods is everywhere. Don't forget to check out other webinars, and good luck.